I will talk about the rationale for key population surveillance, show a little bit the existing surveillance data, talk about methodological challenges a little bit, population size estimates, case-based surveillance, maybe as a way forward, and make some conclusions and recommendations. In Asia, there are more than 90% of people living with HIV in 5 countries. If you look at the pie chart on the right side, the majority are in India, China, Indonesia, and Thailand. If you look at new HIV infections, it mirrors it a little bit, but then Indonesia actually is bypassing China, and also Myanmar and Vietnam are higher in terms of new HIV infections compared to Thailand. But the majority are in the big countries in the region. So the epidemics globally are determined by 4 key populations: men who have sex with men, people who inject drugs, sex workers, both female, male, and also transgender sex workers, and mostly transgender women. So it's for epidemic control, it is very, very important to be able to identify these key populations to target your interventions at those populations which are most vulnerable to HIV transmission. Not only to HIV transmission, but also STI and hepatitis transmission. Unfortunately, there are no gold standards for defining these populations. The definitions vary across different countries, different regions, and particularly in surveillance, sometimes you compare apples and oranges. And one good example is that often MSM and transgender are lumped together as one surveillance group, and you don't really know what you are looking at. So the behaviors are lumped together. You don't know the duration with the risk. Are they old or new drug users, for example? And the gender is problematic for the different subpopulations. Globally, key populations have 12 to 50 times more 12 to 50 times more likely of being HIV infected compared to the general population. The highest actually in transgender women, where we have the least data. And we know that HIV services must reach at least 80% of the population to halt the HIV epidemic. And we also have learned that sex worker-driven epidemics can result in general population HIV prevalence up to 10 to 12% as a consequence. So let's look at the snapshots. What are the population attributable fractions of HIV today? These are data from 2014 from the UNAIDS data hub in Bangkok. And you can see that the transmission of or the new HIV infections and the population attributable fraction of HIV do not match. So the population attributable fraction is mostly in the general population. It's a mature HIV epidemic, whereas the new HIV infections have shifted to MSM in Thailand. If you look at a more younger HIV epidemic like the Philippines, and I see that someone from the Philippine AIDS Society is here, you see that the population attributable fraction and the new HIV infections, they match. It's mostly among MSM. So how have we been doing with surveillance? There are a huge number of surveys which have been conducted in many countries in Asia among key populations. But the key is really the systematic serosurveys. There are few more serosurveys. There are not many, but there are systematic serosurveys. And the idea is really not to have many, many surveys which are not comparable among each other, but to have standardized tools, systematic routine surveys which are comparable, and not only among key populations, but also in general population like ANC attendees. If we look at behavioral surveys, they are now available in most countries. You can see that about 50% of countries surveyed, these are 26 countries in Asia which were surveyed, have behavioral surveys in all 3 populations, and another 30% in 2 populations. So you capture probably with behavioral surveillance a significant number of countries and have quite a good grasp on what's happening in behavioral surveillance. So some countries also have integrated biological behavioral surveillance. Other countries use behavioral sentinel surveys. So key populations are challenging to survey because of stigma and discrimination. They are not difficult per se, but the methods we have and the outreach we use in the context of stigma, in the context of discrimination and criminalization, make it difficult to find, to identify key population members. They're socially hidden, we have poor geographic information, unknown population sizes, stigmatized and criminalized, so they're reluctant to enroll in surveys, and there are reporting biases in interviews. There's also poor access to services, and so it's a challenge to estimate service uptake, as individuals may not identify as key population, and in consequence also it's very challenging to sample through facilities. But we are basing all our funding decisions on surveillance data among key populations. Like, for example, PEPFAR, many development partners are focusing their funds where HIV is occurring, but the data we have are sort of not the best, actually. So how do I do this? Okay. So issues frequently encountered with key population surveys over the past years and still today is that we have poor adherence to protocol, to sampling, to data collection and analysis. Often it is also that governments who are responsible, the Department of Epidemiology, they may not be very well equipped to conduct the surveillance in key populations because they are part of the system which creates stigma and discrimination and also criminalizes individuals. So it's complicated. Then often trend analyses are not done and data are just looked at year by year, but you could actually use already the available data. And what is also glaring is that we don't have HIV incidence data in key populations. There are very few incidence data available. They are more from clinic-based data, notably from Bangkok, from the Ceylon cohort. But much more should be done if we want really to understand what we are doing and how our interventions are making an impact. So if we do surveys, we would really like the surveys or the surveillance to be representatives. It's like in a clinical trial, you want to have a representative sample. So each individual included in the surveys or in your study must have the same probability of being sampled or recruited into the survey. And there are certain methodologies which do that and others are not. So key populations are difficult to reach, so the majority of surveys actually use non-probability sampling like convenience, purposive, quota, and also chain referral sampling like snowball indirect sampling. These methodologies are prone to bias. So the probability-based sampling is much more difficult to do, but there are surveys which have used these methodologies which are a little bit better, but also prone. There are also issues around these methodologies. So the best is the conventional cluster sampling, which has been rarely applied actually amongst key population surveys. The most commonly used are actually time location sampling or venue-based sampling and respondent-driven sampling. So what are we talking about? So time location sampling is mapping the universe of physical venues where target population congregates, for example, methadone clinic or MSM clinic. They randomly select a day, time, location for the recruitment and systematically selects participants from time venue units. The respondent-driven sampling is a modified linked tracing recruitment. It recruits per enrollee, which is sometimes so limited per enrollee. There's a certain number you are enrolling, not like Snowball where it's open-ended. And the respondent-driven sampling has a special software which looks at the referral patterns and participants reported and the social network sites and can produce also population size estimates. These are not perfect methods, and here are some examples. This is a survey, respondent-driven sampling survey among MSM, which was conducted in Zanzibar in Tanzania by the same study team. You can see the same study team with the same protocol did the survey in 2007 and then again in 2011. And you look at the data and it's 2.6% in 2011. So someone could come and say, wow, we have a huge increase. But it's also likely that in the 2 rounds, you have sampled at different subsets. So you have to be very careful how you interpret the method and use the data you have generated. These are examples from Vietnam, from the IBBS study from the Ministry of Health. And if you compare the surveys done on HIV prevalence and injecting drug use and compare them, you can see that in 2009, where the HIV prevalence was highest, that probably you have included more sex workers who injected drugs than in 2006 or 2013. But from the surveillance data alone, you would think, oh, maybe there was an increase in sex workers there are more HIV in sex workers, but no, maybe it's more related to injecting drug use. These are from the same survey where you looked at free condom distribution. The free condom distribution in Vietnam to sex workers has increased incredibly during this time period. But if you look at the behaviorist survey data, it doesn't match. So the number of sex workers who received free condoms was lower during this period, and also those who consistently used the condoms was also lower during this period. So we are not really sure what's happening here, but it shows that there are weaknesses in the survey methodology we are using, and we have to be careful how to interpret that. So now I'm showing some surveillance data from Thailand. Thailand has traditionally one of the strongest, or historically one of the strongest surveillance system in the region, has invested a lot in the surveillance. And here you see the HIV prevalence in male sex workers in the National Sentinel HIV surveillance in Thailand is very high. And these are data which are true, we believe in them. So I'm showing an example. These are not published data on the reports the Ministry of Public Health was receiving from the different, so by province, and you can see like they received 5 reports from Chiang Mai, 3 from Chonburi, 10 from Phuket. Phuket the surveys were done a little bit outside of the MOPH system, but you can see also that there were no report from Bangkok because of the administrative divide in Thailand. And if you look at the samples included, you can see the difficulty to sample actually in some of the provinces. But if you look at Bangkok, we all know that HIV prevalence in Bangkok is very high among MSM and mostly among the male sex worker population as well. What we see also in Thailand is actually they have very good data to show that the number of people who inject drugs is going down, included in the Sentinel survey. So can we still do good HIV surveillance in this population? Do we still have drug users? Are they gone? Have they died? Or are there just less injecting drug users in Bangkok? So it's probably a combination of all of that. But it shows that how complicated it is, and you have to adapt your surveillance system really to the changing pattern of your epidemic. So now let's look at population size estimates. It's very important because we are talking about coverage and UNAIDS and WHO, and everyone talks about 90, 90, 90. 90 of what? So we estimate the population size, and there are different models from UNAIDS, the spectrum, there's the Asian epidemic model, and these are data from a systematic review by Keith Sabin in 140 low and middle income countries, and we could see that at least 71% had at least one estimate for one population, and 50% had, only 50% actually had sort of representative sample according to UNAIDS criteria. So about 30% had nationally adequate data, and about 20% had not nationally adequate data, but locally adequate data. 62% had population size estimates for 2 groups, and 40% for 3 or 4 groups, and 6% really for all 4 groups, including transgender. So, but if you look at population, many countries had population size estimates for MSM and female sex worker, but again, you see very little for transgender women. So the traditional methods most commonly applied for population size estimates are multiplier, capture-recapture, census enumeration, and programmatic mapping. And for those who are medical doctors, clinicians, so these use as, for example, the multiplier method looks at how many, for example, injecting drug users you have in methadone treatment. If you say 60%, and your clinic data show you have 3,000 clients going through the system having received methadone, hence you estimate the population size dividing the 3,000 by the percentage, and you have about 5,000. That's the estimated population size. So this is how the data are generated. For female sex workers and MSM, 1/3 of estimates and used census enumeration and programmatic mapping. And this kind of methodologies can also be used to improve the understanding of the typology and places where risk behaviors occur. So now epidemiologists are looking at new approaches. There are a lot of chatting sites, applications, dating tools, and they present really challenges, but the pattern of communication where people go is changing. And how do we include this kind of new internet-based, web-based, and application-based communication and how do we use it for surveillance? And respondent-driven sampling, which is a more recent method used, is used to estimate the respondent network size and to estimate the proportion in service. And there's a software which comes up, which I already mentioned before. So in WHO, in the regional offices in Asia, given that population sizes are decreasing, HIV is not decreasing, but HIV infections remained low over the last years, 8 to 10 years. We are more and more looking at using case-based surveillance and monitoring among key populations. And actually this would require that you have some sort of unique identifier code, and there are not many countries of the many low and middle income countries who have these unique identifier codes, but once you have that and you combine it with the biometric, you could link actually the data you're generating from different individuals, starting from refer to testing, from the outreach to tested negative, tested positive, linked to care, and started on treatment and ultimately virally suppressed and dying. This doesn't come without caveats also, because it has to be a very protected system to protect the individuals who are being surveyed in this. But if we look at these data, they actually generated by FHI 360, they look at HIV performance and monitoring for 2 NGO government programs serving people who inject drugs in Cebu in the Philippines. So they've keyed in the data retrospectively, and you can see from on the left-hand side the bar from how many are reached and tested, received result, and it shows you how your service is doing. Again, here, an example from Thailand, the cascade using case-based surveillance and monitoring among key populations, among men who have sex with men, people who inject drugs, and female sex workers. So this kind of case-based surveillance and linking it to uptake of services, the so-called cascade, it's a very useful tool actually to understand how you're doing with your service. And the sad story is that if when you see how few of the key population members who are starting treatment are virally suppressed, and those who are not virally suppressed are going around and infecting others. So that's an important information you would like to have. So surveillance must really provide a bit better picture, and there's still a lot to do to improve our surveillance method. We would like to better articulate the subpopulations, to look at identities, sexual identities of MSM and transgender separately, to also disaggregate male sex workers from the overall MSM population, for example, and understand the sexual networks affecting the risk. We also have to address the evolving culture like internet, mobile, and networks, and understand also the pattern of drug use. It's shifting. What's important also now, in particular in Asian epidemics, but everywhere actually, is to understand the structural determinants affecting visibility and risk, like violence, stigma, and the legal and cultural context in which we are operating. And we have heard yesterday, actually, from Jintanat, even in HIV cure research, you're looking at social sciences. But we should also complement our surveillance methods with formative ethnography and rapid formative surveys, which add value to design specific prevention strategies which inform you how to better, for example, administer PrEP. If you have a formative survey among MSM which tells you about their needs, and it helps you also to design strategies to identify, locate, and reach various group of people and practices. So in conclusion, there is a lot of we have done not so bad, but there's always room for improvement. In particular, there's a lack of HIV incidence information in key populations, and we have seen their examples. We have the technologies which are being developed where you could try to approximate at least the HIV incidence. There are still poor sampling methods and low data quality given the way how the surveys are being done. There's also a lack of in-depth analysis, and available data are often not fully analyzed, understood, and also not used. They're not reported. There are lots of data being generated, but they don't get to the user. They're often not connected to programs, and sometimes not even connected to your epidemic. And the population size estimates, as sad as it is, they are not yet adequate, despite the global call by many agencies for reporting program coverage. So the recommendations would be to improve consistency of surveillance surveys on key populations, including for transgender people, to explore ways to conduct online surveys. So governments and NGOs actually should collaborate to improve surveillance among key population, especially to address the prevailing stigma and discrimination. And there's so much time really spent on data collection rather than analyzing and interpreting the available data. So I would like to acknowledge Lynn in my team, the epidemiologist, who has actually made most of the slides in this talk, and Fritz, who has helped generating some of the slides, and Jean-Louis and Annette for reviewing the slides. Thank you very much.